Dr. Mohamed Zakari with title of PET-MRI Neurological Applications.
Thank you, sir. Thank you, sir. A brief talk about PET-MRI neurological applications. Okay. First, I would like to thank Professor Hisham for giving me this great opportunity, and Professor Yasser Abdelazim, who helped me in updating this lecture. Also, I'd like to thank Professor Rasha and Professor Ikhlas for the great introduction. They paved the way for me to start. I'm going to talk briefly about PET-MRI neurological applications. What is hybrid PET-MRI and when to do it, and what are the neurological applications of PET-MRI? Hybrid PET-MRI combines anatomic and quantitative data obtained from MRI with the biochemical and molecular data of PET simultaneously. Also, multiple MRI sequences are added depending on the clinical question that is to be answered. When to do PET-MRI? When both PET and MRI are necessary for patient management. To start with the PET-MRI neurological applications, the main applications are brain tumors and brain metastases, epilepsy, neurodegeneration, mild cognitive impairment, and dementia. The value of PET-MRI in brain tumor and metastasis is tumor grading and differential diagnosis, tumor extension delineation and treatment planning, treatment follow-up, and delineation of the regions of tumor highest grade for biopsy planning, and it's also more effective in planning radiotherapy field by targeting active viable tumors. Finally, for following up response to therapy to detect recurrence accurately, comparing tumor size and viability by PET. The tracer used here are the first and the most important is fluorine FDG. The second, amino acid tracers like fluorine fluoroethyl tyrosine, and carbon 11 methyl methionine, gallium PSMA, and gallium dotatate. Our first case was a history of metastatic lung cancer, received radiotherapy coming for follow-up. To the left, T1 post-contrast image, we see a large enhancing component. On reviewing the fused PET, we can see a smaller active tumor. This delineates the residual lesion and the post-treatment change or fibrosis. This case using fluorine fluoroethyl tyrosine. As we can see here, a considerable portion of FET PET tumor volume extending beyond the area of contrast enhancement and is also partially located outside the areas of flare hyperintensity. Another case using carbon 11 MAT in a case of a cerebellar low-grade glioma with good delineation of the active component. Another case, a post-operative PET MRI using gallium PSMA, detecting accurately the recurrent or the residual lesion. And another case using gallium dotatate in a case of a recurrent anaplastic meningioma treated with surgery, stereotactic radiosurgery, and brachytherapy radiation. As we can see here, an enhancing component with corresponding avid gallium dotatate uptake at the first two rows. At the third row, we see a heterogeneously enhancing lesion with no corresponding gallium dotatate uptake, which represent post-treatment changes. The last case in brain tumors and central nervous system tumors is easy and accurate detection of spinal axis tumors, like this case, which was an astrocytoma with delineation of its active component. The second application is epilepsy. PET-MRI can identify lesions responsible for medically refractory epilepsy, like temporal lobe epilepsy, focal cortical dysplasia and tuberous sclerosis complex. The tracer used here is fluorine FDG. What is the role of the FDG PET-MRI in epilepsy? It can detect the regional hypometabolic lesions that are highly probable to represent epileptogenic foci. Detection of the most epileptogenic lesion, as in cases of tuberous sclerosis and multiple zones of focal cortical dysplasia. It also detects all areas of hypometabolism, which is usually greater than the abnormality seen by MRI, as in mesial temporal sclerosis and focal cortical dysplasia. And finally, it differentiates autoimmune encephalitis and limbing encephalitis from mesial temporal sclerosis. As in encephalitis, the hippocampus is hypermetabolic, while in mesial temporal sclerosis, it is hypometabolic. Our first case, there's on the T2 axial T2 image, there's subtle blurring of the parahippocampal gyrus with matched area of decreased uptake of the FDG. In this case of tuberous sclerosis, for pre-surgical planning, MRI can detect the most active tuber responsible for most of the epileptic activity, helping in planning the surgical resection and reducing the epileptic attacks. The third application is neurodegeneration, mild cognitive impairment, and dementia. We have here two steps. The first is to exclude other causes of dementia by CT or MRI, like cortical and deep brain nuclei infarctions, normal pressure hydrocephalus, and marked intracranial mass effect. The second step is to identify the type by the PET-MRI. PET-MRI allows more reliable diagnosis of dementing disorders, as well as prediction in pre-dementia stages by detecting the specific patterns of regional hypometabolism or uptake according to the tracer, which indicates neuronal dysfunction and change in the neurotransmitter system. The tracer used here are fluorine FDG, amyloid plaque tracers, and tau tracers, and F-DOPA. PET-MRI in Alzheimer's disease is mainly manifested by hypometabolism in temporal lobes and sometimes in frontal lobes, posterior cingulum gyrus, and precuneus. In this slide, we have three different cases. To the left is a normal case with normal FDG uptake. Another case with decreased uptake of Alzheimer with decreased uptake at the precuneus. And the third was frontotemporal dementia with decreased uptake at the frontal region. The second tracer is amyloid, and the principle here is different because we here detect positive uptake. We are detecting or targeting amyloid plaques, and these plaques are targeted by the amyloid plaque tracer. So the first row is negative scan with no uptake, and the lower row with frontal uptake, there is a positive scan. The second tracer, or the third tracer, is tau tracer. The same principle of amyloid. We are targeting tau, the position of abnormal tau tracer. To the left is a negative scan, and to the right is a positive scan with uptake in the frontal region. Finally, in diagnosis of Parkinsonism, we use a different tracer, which is F-DOPA. We target normal dopamine synthesis. So in a negative scan, there is normal uptake in the caudate and the putamen, as we can see to the right side. And in positive scan, there is decreased uptake in the caudate and the putamen, denoting or diagnosing Parkinson's disease. To conclude, the value of PET-MRI in brain tumors and metastases is tumor grading and differential diagnosis, detecting viable tumor tissue extension, aiding in biopsy and radiotherapy planning, detecting residual viable tumor tissue post-chemotherapy and radiotherapy, aiding in treatment follow-up, better detection of metastases, more in small ones, and within the skull base and spinal axis. In epilepsy, it helps in detecting epileptogenic foci in MRI negative cases, detecting most epileptogenic focus in cases with multiple lesions, like in tuberous sclerosis and focal cortical dysplasia. Also, it aids in surgery planning by detecting epileptogenic foci. Finally, in neurodegeneration, mild cognitive impairment, and dementia, It differentiates between types of dementia at early stage, particularly Alzheimer and frontotemporal dementia. It predicts decline from mild cognitive impairment to Alzheimer's disease, and it's used in follow-up after treatment to monitor therapeutic response. Thank you.
شكرا دكتور محمد for this informative and concise presentation. Is there any question for Dr. Mohamed? اوكي شكرا وبننهي الجلسة ونشكره على الحضور.